The lateral ankle is made up of 3 ligaments: the anterior talofibular ligament, or the ATFL, the calcaneofibular ligament, or the CFL, and the posterior talofibular ligament, or the PTFL. 60 to 70% of lateral ankle sprains are sprains of the ATFL, and the remaining 20% are of the CFL.
Subjective questioning is a very important part of the exam. It allows us to determine if risk factors are present. It also allows us to get detailed information about the injury from the patient. Subjective questions include: what brings you in to see me today? Where exactly does it hurt? Can you point to the pain? On a scale of 1 to 10, how intense is your pain? Can you describe your pain? Like, is it burning? Is it tingling? Is it stabbing, shooting? Have you injured this body part before? And does anything make it better or worse?
During the exam, we will look to see if there is any loss in the patient's range of motion for plantar flexion, dorsiflexion, inversion, and eversion. These will be tested actively and passively. In a full ankle evaluation, you will want to palpate all the bony, muscular, and ligamentous structures, but our focus will mainly be the 3 lateral ankle ligaments, the fibula, and also the lateral malleolus. When performing manual muscle testing, start with Kendall grade 3 position to determine the strength of the particular muscle. If this is not achieved, you can assume that the muscle is weak.
So for the anterior drawer test, we're going to have the patient sit with the knees in 90 degrees of flexion. One hand should be on the distal tibia while the other hand should be holding onto the posterior aspect of the calcaneus. The test is performed by stabilizing the tibia while giving an anterior force to the calcaneus and thus the talus. A positive test would show increased motion in the involved ankle. The sensitivity of this test is 0.8 or 0.80, and the specificity is 0.74. For the talar tilt, have the patient stay seated with the knee in 90 degrees of flexion. One hand should grab the distal tibia and fibula while the other hand grabs the calcaneus. The test is performed by inverting the calcaneus and thus the talus. Again, a positive test would show increased motion in the involved ankle. The sensitivity of the test is 0.50 and the specificity is 0.88. To rule out a fracture, we can do the squeeze test. Perform this test by using 2 hands to squeeze the tibia and fibula to see if that introduces additional pain. This pain can be representative of a fracture. We can also use the bump test to rule out fracture. Simply bump the patient's heel with moderate force with the heel of your hand to see if this produces additional pain. Ottawa rules are another tool to determine if a radiograph is needed. If they have pain along the posterior edge of the lateral malleolus, or if they are unable to bear weight, then they may need to go get a radiograph to rule out a fracture. Functional testing can be used to determine return to play protocol. We want functional testing to be sport specific. This can include things like lunges, squats, jogging, gait, running, and cutting.
During phase 1 of the treatment aspect of a lateral ankle sprain, we want to make sure to control pain and edema. This can be done by rest, ice, compression, and elevation. E-stim can be added for additional pain control. The patient can begin range of motion exercises such as ankle pumps and toe curls. These patients will be non-weight bearing and will possibly have some type of immobilization or stabilization such as a brace or cast. During phase 2 of treatment, hopefully the patient will be partial weight bearing with little to no pain. Strengthening exercises will be added into the rehab program along with some type of easy bilateral balance training. Phase 3 of treatment progresses the patient into more unilateral balance training and also unilateral heel raises. It is important for the patient to start walking on the treadmill or even on the ground to regain their normal gait. Eventually, during this phase, you will want to progress the patient to a fast walk. The last phase, or phase 4, is where we are going to see more sport-specific training for this patient. They will progress from a jog to a sprint, as well as adding some shuttle runs and cutting into their program. An ankle tape job should consist of anchor strips, 3 stirrups, 3 horseshoes, 2 medial heel locks, 2 lateral heel locks, and 2 figure 8s.